Good afternoon, everybody. Hello, guys.
We'll start.
Well, good afternoon, everybody. Thank you for the invitation to be here. It's always a pleasure and an honor to talk to all the division, the fellows. Today we're going to talk about the clinical approach of long nodule mediastinal staging. What I mean by that, and this is after discussing with some of the fellows to get in some ideas, the goal would be to address the issue of what happens with a patient, or what happens with us, what do we do when a patient shows up in our clinic, or we're asked to evaluate a patient with an abnormal CT scan, and we have a high suspicion for malignancy, for lung cancer. So what do we do with those patients? So we're going to try to answer that question after all this talk. So first, talk about approach to lung nodule that is suspicious for cancer. We'll go over some words over a staging of non-small cell lung cancer, the new edition that probably most of the fellows already know and have memorized already by now. Clinical evaluation, how important that is when we see a patient, when we approach a patient with possible lung cancer. CT and PET scan give you some ideas of when we should order them. Then we go about this radiographic evaluation, the initial radiographic evaluation. There are different groups that we can put all these patients, and that will help us approach patients with suspicions of lung cancer. Then we'll go to a mediastinal staging of lung cancer, the different techniques, non-invasive techniques, invasive techniques, and then we'll go to conclusions. So I'm sure that all of us have encountered patients who come to our clinic, or as I said, even in the inpatient setting, with this type of CT scan. So what do we do from them? So obviously we diagnose the patient with a lung nodule or a lung mass, or however you want to call it. How do these patients come to us? Usually either because a physician ordered a CT scan for another reason and it was an incidental finding. Other primary care physicians may have already used the recommendations by radiology and followed the Fleischner's guidelines. Maybe it was time at that moment to refer the patient to pulmonary, and then that's how we got the patient. Or it was because the patient was found a nodule that looked suspicious by a lung cancer screening CT. Or because the patient presented to a primary physician or to any other physician and had respiratory symptoms that could be compatible or consistent with a suspicion for lung cancer, like hemoptysis, chronic cough, etc., and they found this nodule. So after we do that, we see the patient, we see the images, we know that we make the diagnosis of lung nodule, then we believe the next question is this suspicious enough for lung cancer? And there are different prediction models that have been already published, and probably I've seen many of you using different calculators to decide whether this nodule looks malignant or not, based on variables like radiologic variables, speculated size, location, etc., and other clinical or risk factors like age or history of family history, etc. This is probably the one that is the most commonly used, and the one that has already been it was already published in England in 2013, and it was based on a Canadian lung cancer screening program, and using all the different variables as you can see here. But anyways, regardless of which element or which calculator you use, you decide that this patient has enough suspicion for lung cancer. So the answer is yes. So this patient is suspicious enough for lung cancer, so I need to continue with the path. So what is the next step? Staging. And I'm talking about a staging, not in the sense that once you diagnose the patient with lung cancer, but also in patients who you suspect have already a lung cancer. What can you do for staging the patient? Because this is what's going to guide you in terms of where to obtain that biopsy from, what type of technique you may consider to obtain the biopsy, etc. So these guidelines were written in 2013 by the ACCP in terms of what are the different methods or techniques or how to approach patients to stage non-small cell lung cancer. Not only, as I said, with patients who already have a diagnosis, but also the ones that you suspect diagnosis of lung cancer. First of all, we need to be familiar with the 8th edition of the non-small cell lung cancer staging. Very similar to the 7th. The few differences are pretty much in T1. They added on one more, which is the T1C, and it's pretty much just variation in numbers and sizes. T2 also, there were some variations in sizes. T3 and T4 remain almost the same. N, which is the lymph node part, has not really been touched, so it continues to be the same, has continued to be the same for the last 15 years almost, or more. And the metastatic part, which is M1, has just a tiny variation, and they added on M1C to the M1 and M1A that had before. The intention is not to go over all this table. You can have it really handy even on internet. But it's important to know why. Because the next step, after you see a patient who comes to you with a lung nodule that's suspicious for lung cancer, then it's a clinical evaluation. What does a clinical evaluation can give you? Which information? I mean, patients could come with constitutional symptoms, that could be suspicious for cancer, pain, musculoskeletal pain, that can guide you in terms of, well, maybe the patient is already having a metastatic lesion in the bone. Some neurologic symptoms, neurologic deficits, that can tell you maybe the patient is already having a metastasis on the brain. Hoarseness, that can give you an idea of that T. If the patient has a vocal cord paralysis, then you're talking about a T4 lesion already. And then routine labs, for example, hemoglobin or low hematocrit, low hemoglobin, elevation of LFTs that could go more with liver metastasis, or hypercalcemia with bone metastasis. So after you do a clinical evaluation, then the next step is, let's go over the CT chest. Many of these patients will come to you with a CT chest either with contrast, non-contrast. Sometimes it's just a PE protocol, it's a lung cancer screening CT, low-dose CT, etc. So the recommendations given by the ACCP, even though they were given in 2013, by the way, they still work for the new classification because it hasn't really changed that much. If the patient is eligible for treatment, then a CT chest with contrast is recommended. So your job at that moment is, let's see, we need a CT scan with contrast. And why is the contrast part? Pretty much to evaluate the mediastinal area. Now, there's another caveat here, and this is eligible for treatment. It's always difficult to decide on this. However, be aware that once you start the whole pathway of evaluating somebody for lung cancer, it doesn't really stop on a CT scan. I mean, it's going to go all the way. It can go to PET scan. It can go to bronchoscopy with the staging. It could go to a IR with CT-guided biopsy. It can go all the way to surgery. So you have to make sure that this is what the patient wants. And number two, that the patient is really eligible for this treatment. If the patient has an ECOG score of 4 or 3 or 4, it's probably not eligible for this kind of treatment. So maybe you shouldn't start with this route or this pathway. Now, the guidelines also mention that, well, if there's no CT scan with contrast, maybe you could pursue a PET scan. This is right now in debate. And most of us probably have had these issues with insurances trying to approve a PET scan in somebody who's not diagnosed with lung cancer yet. And it could be difficult because the guidelines are pretty specific for just one population. We're going to talk about that in a minute. But PET scan can give you overstage patients. Not only that, can give you targets that may not be able to be biopsied, may confuse the patient, may confuse the diagnosis even further. So we just keep it in mind. They also mentioned if a PET scan cannot be done, then a CT of the chest involving or including the upper abdomen to evaluate for adrenal glands and liver metastasis. That's pretty much what we should do when we have a patient with a suspicious lung cancer. So what are these kind of images will provide us? It will provide us in helping determine, number one, if there or what is the extension of an extrathoracic involvement. Let's see if there is an adrenal metastasis, a possible adrenal metastasis, is a liver metastasis. And two, will tell us also the extension of a thoracic involvement. Will give us a better information of the mediastinum too. Let's put that thoracic involvement, for later. We'll talk about this extrathoracic involvement. So what are the guidelines? What is the guidelines in this kind of patients to determine whether there is extrathoracic involvement or not? So, yes. Yes.
So something I consistently struggle with is you get a patient who comes in with a CT scan without contrast for 100 different reasons, who has a 1 centimeter nodule in the right upper lobe, and then there's something in the mediastinum that's maybe lymph node, maybe not, depending upon when we go to the radiologist on the given day. That patient's going to need a PET scan for staging no matter what anyway. So why would I subject them to the radiation of the CT with contrast and then the PET scan on top of it, as opposed to just getting the PET scan?
Oh, no. That's so. I think I wasn't clear about that. PET scan could be done. It's just the problem is in some areas that you don't have a PET scan availability. Or if you're, as I said before, and probably most of us have had to deal with insurances, for example. Try to get an approval, it's not approved, so it's really, it can be a hassle to try to obtain a PET scan in this patient.
So you can get a PET scan and there's really no reason to do a contrast and CT?
Correct, okay. Yes. So it's either or, it's not both.
I was going to ask, do all of our CTs with contrast always go down to the level of the adrenal?
Not all of them. Unless there is a protocol says that there actually says for lung cancer. If you suspect for lung cancer, radiology immediately goes down.
Just you order a CT chest with
CT chest with contrast for lung cancer. Yes.
Okay.
So let's talk about a PET scan. Different studies have been done. Reviews of different either retrospective or prospective studies. This is a meta-analysis with more than 50,000 or 5,000 patients with a PET scan. Really shows a sensitivity of 85% for lung cancer and a specificity of 90. PET scans have also shown in different studies an incorrect upstaging. You'll see a lot of lesions that may not be metastatic lesions on PET scan, and then you incorrectly upstage the patient to a stage 4, and you already are saying, okay, the patient has a stage 4 lung cancer, we shouldn't do anything, or this is the treatment. So it can go up to 40% depending on the study. PET scan can also find you without a CT scan correlation, and I'm sure that you've seen this before. You see lesions in the trachea that pretty much end up with just being mucus sitting on the trachea or in the airways, and they show up as hypermetabolic. What PET scan really should be used for is to try to identify potential targets, not necessarily to help with the staging of the patient, but to identify potential targets that you definitely will have to confirm with tissue sampling. If the patient is having an adrenal gland that is hypermetabolic and possible consistent with the metastasis, the patient should go for that first. So this is when we're starting to enter the part of biopsy. So we haven't diagnosed the patient yet with lung cancer, but now, because we're doing this, if we find any extrathoracic or any other lesion that could be a biopsiable, that could be related to a metastatic lesion, then we should go ahead and pursue that biopsy. For Mediastinal assessment, is really equivocal. It's not really recommended at this point. So we should never order a CT scan or a PET scan, in patients who, just to evaluate the mediastinum, but rather to evaluate the extrathoracic involvement. So the guidelines. If the patient has a normal clinical evaluation, right, there's no suspicion of extrathoracic abnormalities on chest CT, and this is probably the only way that the PET scan is available for, and is being considered for a curative intent treatment, meaning you're thinking about surgery for possible stage 1 or stage 2 maybe, or radiation therapy for that, then a PET scan imaging is recommended. Only in that scenario. You haven't made a diagnosis yet, but you suspect enough that this is lung cancer, and the patient doesn't have any other symptoms extrathoracic. You don't suspect that the patient has metastasis, and you're going to offer the patient a therapy with a curative intent, then a PET scan is recommended. And we're talking about those stage 1s that we see sometimes, nodules, peripheral. PET scan, they usually approve it. It's actually easy. You don't have to talk to anybody. They approve the PET scan. Patients go for surgery after that. If the PET scan is not available for multiple reasons, you can pursue a bone scan and a CT scan of the abdomen, the entire abdomen, to look for metastatic lesions. Now, if you find something on the PET scan or another scan that is suspicious for a potential metastasis, then you should pursue tissue sampling. Okay? Yes?
I thought that if you suspect that it's 1A, and if you don't get a PET scan in that case, we think that it's localized as 1A. Is that the case?
If this is stage 1, if a clinical stage 1A,
yeah.
Yes, you should get a PET scan to make sure that there's nothing else around in the extrathoracic, and that shouldn't be an issue. You get a PET scan and then you send it for surgery.
So what you may not need an early stage the brain MRI. So based on what guidelines you follow and whether it's ACCP or NCCN, then probably for a stage 2 or above, then you will need a brain MRI. For anything else you don't.
Perfect, and I was going to talk about that right immediately. So yeah, so you're right. So other studies like this one showed in 60 patients that they found occult brain metastasis when in patients who had the primary lung tumor, the primary lung cancer being more than 3 centimeters in size, pretty much a stage 2 and above. So what do you order, a CT scan of the head or an MRI? Pretty much, MRI is more sensitive to see metastatic lesions. However, it's actually questionable whether there's going to be a difference in mortality in these patients. And those previous studies were done only with CT scan of the head or MRI. And if mortality doesn't really change, then maybe there's no point in ordering an MRI. Although the recommendation is, yeah, if the patient has a clinical stage 3 or 4, then an MRI, or I would say an imaging of the head is granted. Especially, ideally, a head MRI, but if not available, then a CT scan of the head. Any questions up to here? So, recapping. If the patient presents to you with a lung nodule or lung cancer that you suspect with a lung nodule that you suspect is lung cancer, you go over these things first, trying to look with a physical examination, with further CT scan, or sometimes a PET scan, depending, with areas in the other outside or extrathoracic areas to look for metastasis. If the patient comes, let's say, with a neurologic deficit, you go for the MRI first of the brain. If the patient comes already with a bone pain, then you go probably for the bone scan and probably biopsy that first, before you even try to biopsy the primary site. So now, what happens? What happens when you don't find any of this? Patient comes to you with a nodule or findings on the CT scan. The clinical exam is normal. There's no the CT scan that you already ordered or maybe already came with a PET scan is not showing anything around. So how do we approach these patients now? So the guidelines, again, the ACCP, they divided the group they divided these patients into 4 groups. And this is, and I know the fellows will go through all these groups when they rotate through bronchoscopy, because this is kind of tells you what to do. Or so the group A, you have the patients with mediastinal infiltration. Pretty much patients who have the tumor that has already infiltrated the mediastinum, or just some lymph node, a tumoral lymph node that has already infiltrated the mediastinum, that is not allowing you to localize the other lymph nodes around. And we're going to show you a picture in a minute. That's the group A. Group B, most of the patients probably that we see, enlarged discrete mediastinal nodes. You just look at the CT scan, lymph nodes are 1 centimeter in the short axis diameter, or bigger than that, and you can distinguish very well those lymph nodes in the mediastinum. We're talking about mediastinum, not hilar lymph nodes here. Okay, this is all based on CT scan, not on PET scan. Group C is what it's called the clinical stage 2, or the centrally located tumor. So you have either a patient who has an enlarged hilar lymph node, meaning an N1 lymph node that is more than 1 centimeter again in size, or you have a patient who doesn't have or doesn't show any hilar or mediastinal lymph node, but has a tumor that is centrally located, meaning within 1/3 of the hemithorax. Okay, why is that important? Because you can still find in this population up to 20 or 25% of the time enlarged lymph nodes in the mediastinum once you do the mediastinal stage. And then you have a group D, which is the classic stage 1 possible lung cancer, peripherally located nodule less than 3 centimeters in the periphery, in the outer 2/3 of the hemithorax. Group A, you see infiltration of the mediastinum. You cannot really make or distinguish their lymph nodes at all. It's just a big mass. This is regardless of what's happening on the lung parenchyma. So it's either a lung nodule or a lung mass. Group B, you are able to distinguish the mediastinal lymph nodes. They are more than 1 centimeter in size with the short diameter, or the short axis diameter. Group C, the 2 subgroups. One is either you have an enlarged hilar lymph node and the mediastinum being normal, or you have a centrally located mass in the 1/3 of the hemithorax. And group D is the classic peripheral located nodule less than 3 centimeters in size. As I said, all this categorization is done based only on CT scan, not on PET scan. So if you have a PET scan, you go to the CT image associated with a PET scan and start doing this. So we're going to talk about mediastinal staging in lung cancer. So when do we do it? Based on those that classification with the 4 groups. First of all, let's talk about lymph nodes, and we're all familiar with that. The anatomy of the lymph nodes are pretty much, the nomenclature goes from 1 all the way through 14, and they're associated actually in different zones: the upper zone, the epizone, the subcarinal lower zone, etc. This is from the previous TNM classification, but it has not changed. The nomenclature has not changed at this point. And the reason why it was associated with different zones is because when we have different lymph nodes, for example, N1 metastasis or N2 metastasis to different zones, even though they're both are N1 or N2, when you have multi-zone metastasis, the prognosis or the survival is actually worse. Again, anatomy, this is, we go with the fellows over this. So I'm not going to go to that, but just to remind some graphics about station 1 lymph node, right? Station 2R, above the brachiocephalic, and station 3A, the vascular. Station 3P is the posterior tracheal. 4I, the right paratracheal. 4 left, left paratracheal lymph node. Station 5, which is the aortopulmonary window, usually left upper lobe masses or cancers drain into that commonly. Station 7 is the subcarinal lymph node. Station 6 is the pre-aortic Station 8 is the paraesophageal lymph node. Station 11 are S superior, which is between the right upper lobe and the bronchus intermedius, and the inferior between the right middle lobe and right lower lobe, and station 11 left between the left upper lobe and the left lower lobe. Important to know that lymphatic drainage. This is just to see. There was this study in 300 patients with histoplasmosis. Post-mortem, actually, they wanted to see which ones of the lymph nodes were involved. And if you see this, right upper lobe, and we've gone over this also with the fellows, is right upper lobe drains mainly in the hilar, on the right hilar lymph node, which is either 11R or 10R. And then from that, it can go to subcarinal. And if it goes to subcarinal, it crosses the midline and it goes to 4L, for example. Or it can go actually to the right paratracheal lymph node, which is 4R. Now, right middle lobe will do pretty much the same, but we'll go to hilar and then subcarinal. Right lower lobe mostly goes to hilar and then subcarinal, but there's another pathway that they also can take, and it goes to the pulmonary ligament lymph node, which is station 9, and then go to the paraesophageal lymph node, which is station 8. On the left side is a little different. Left upper lobe will go to hilar lymph node, station 11 left or 10L, and from there, a lot of them will go to the aortopulmonary window or station 5 lymph node, or it can go straight from there too. And also involves subcarinal lymph node. And the left lower lobe, it's very similar to the one on the right side, where it goes to hilar lymph node and then subcarinal. Or you can just skip and go to the pulmonary ligament lymph node and then paraesophageal. How to do the mediastinal staging? There are two. I can divide them into two different techniques: the non-invasive staging and the invasive staging. The non-invasive staging pretty much is not really used at this point that much. It can help, but not necessarily. You cannot make a diagnosis or a staging with a non-invasive. But it's good for you to know, because a lot of us, or a lot of pulmonologists still based their staging in PET scan findings, for example, or CT scan findings, before they go ahead and proceed with invasive techniques. So chest X-ray, we don't use it anymore. CT scan of the chest can be used for non-invasive staging, at least to guide, but not necessarily to make the diagnosis. PET scan also can help. So, a few words about some of them. So, CT scan of the chest, just to give you some theory behind it. In this studies, this 5,000 patients, 43 studies, a review, the definition of suspicious mediastinal or lymph node for cancer is more than 1 centimeter in the short axis diameter, which we have talked about it before. It only gives you a sensitivity of 50% and a specificity of 86. So it's not really that much. This review, also done in 2013, pretty much showed the same, very low sensitivity and low specificity in general for CT scan alone and lymph nodes. The advantages is that it can guide you to selectively biopsy the lymph nodes, although it's not really the gold standard for this. It can just guide you and tell you, gives you an idea, but you shouldn't rely on this or just go for that lymph node to biopsy because it's positive or it's enlarged in the CT scan and that's it. Diagnosis of lung cancer definitely helps to try to go with a T, whether this is a T1, a T2, a T3. It helps you with that, give you, and sometimes with M part of the metastasis, and delineates the mediastinal invasion by tumor. Sometimes you have centrally located tumors that are invaded the mediastinal, and they can actually be T4, for example. The disadvantages is still 15% or up to 50% of a stage 1 will have lymph nodes. A stage 1B seen on a CT scan will still have lymph nodes positive in surgery. And 40% of abnormal lymph nodes by CT scan are still benign. So it doesn't really give you a diagnosis. It's not that specific. when we talk about PET CT scans, if you want to know the history, before the PET CT scan showed, it was only the PET scan. And this is how a normal or a PET scan looked like before. There was no correlation or anatomical correlation with the CT. And this is how it looks now. So in the first graphic, you don't know which areas are hypermetabolic. I mean, it could be many places there. But when they make sure and when they mix it with CT scan images, then you can have a better idea of what's going on. It's still not 100% accurate, though. Again, different studies and reviews have shown that the sensitivity for lung cancer and mediastinal hilar lymphadenopathy is actually not that great. It's only 62%, and 90% specific in the setting of lung cancer. PET scan has shown, though, in this study, this prospective study in 60 patients, that compared to conventional staging, which means CT scan at that moment, prevented futile thoracotomies, or was better in preventing futile thoracotomies compared to just CT scan. The advantages of PET scan is has a better sensitivity than PET and CT by itself. PET scan, PET CT, I'm talking about, not, and can prevent futile thoracotomies in general compared to CT scan. The problem is it's not that sensitive overall if the target or the area that you try to evaluate or the abnormal area is less than 8 to 10 millimeters in size. You can still have up to almost 10% of negative lymph nodes on PET scans that are really positive. And it's not specific if the lymph node is above 10 millimeters either. These are the different techniques for invasive mediastinal staging. And you can go all the way from mediastinoscopy, bronchial needle aspiration, the old conventional TBNA, endoscopic with needle aspiration, endoscopic ultrasound, which is the US, which is not done here by us, but is done by a GI, gastroenterology, EBAS, TBNA. Transthoracic needle aspiration is also another way of invasive staging done by interventional radiology, and VATS. So let's go over EBAS. Different meta-analyses have been done already. Sensitivity of almost 90% and negative predictive value of 86%. Pretty high. Even before that, studies like in patients with lymph nodes that were less than 10 millimeters, in these 100 patients with non-small cell lung cancer, they underwent EBAS TBNA bronchoscopy and they biopsy every single lymph node that was less than 10, between 5 and 10 millimeters. And they came up with 20%, almost 20% were positive. So they were not detected by CT scan, or actually they were detected, but they were small to call it suspicious, and they were not detected by PET. So EBAS and PET negative scans. This is a study on 100 patients with a possible stage 1 lung cancer by PET scan only. They underwent EBAS TBNA and biopsy all the lymph nodes that were between 5 and 10 millimeters. And 9 patients had positive lymph nodes. So I'm not advocating, because in here, pretty much in this study is telling us that even the stage 1 that I talked about, the group D, should go for mediastinal staging. I think right now there is not enough data to say either way. I think we need still more data to kind of prove it, whether we should do it or not, in which circumstances, which characteristics of the lymph node, of the nodule, should we be looking at before knowing this. But anyways, 9 patients with positive lymph nodes is a good amount. And pretty much, if you see, 1 was an N3 and 5 were N2. So meaning that 6 patients, they would have gone for thoracotomy for removal or resection of the lung cancer, and they would have had already an advanced lung cancer, at least an N2 or N3. So,
Javier, in that
yes.
study, were those patients that had the positive lymph nodes in the N3 and the N2 disease, were those areas, were those individuals that had no CT evidence of?
Correct. They have no CT evidence, and the PET was negative too. So the PET was also was just positive for the nodule. Pretty much the classic peripheral nodule that looks like lung cancer, the PET scan being completely normal except for the hypermetabolism in the nodule that we send for surgery.
So here I've got, maybe a unique, but here I've got pushback from Zane if he sees something in the mediastinum that is between 5 and 10 millimeters that is PET negative, he wants you guys to go after it first.
And correct. And as I said, there's not enough data right now to support something like saying every single patient, even at stage 1, should go for mediastinal staging or shouldn't.
Okay.
So at this point, right now there's not enough data that we have to say that.
Is that his typical practice? Is that if you see something in mediastinum PET negative, even between 5 and 10 millimeters, he wants you guys to go after it?
Not necessarily. I don't know. I mean, it varies.
Okay.
I have to say it varies, at least with Zane. So radiographic N0 disease. Again, 220 patients retrospective. Lymph nodes were smaller than 1 centimeter in the short axis. And actually, the SUV was low, too. They had a cold lymph node metastasis, meaning they underwent EBAS-TBNA with mediastinal staging. And a cold lymph node metastasis was found in 22% of them. So another part of information that maybe we should pursue a mediastinal staging in every single patient. We don't know. The sensitivity for EBAS was 60%, and the negative predictive value was 93%. The problem is in this study they didn't really gain more information in terms of what was the size of the nodule, or what was the location of the primary tumors. I think that's important to know, because those are other characteristics that can tell us maybe if the patient does have this size of tumor, we should pursue mediastinal staging regardless, or if it's located in so and so lobe, then we should pursue it. This is a multivariable. This is a regression study to predict the end stage that we actually were involved about. 700 patients that we did, and we tried to find out factors that were associated with the presence of N2 or N3 lymph nodes. And one was patients who had a centrally located lesion or nodule. If the patient had histology of adenocarcinoma, then it's very likely for you to find an N2 or N3 lymph node. Or if the patient did have a PET scan that showed an N2 or N3 lymph node, because as I said, still right now up to this point, there's no enough data that even if the patient shows with a PET scan showing that it's positive for N2 or N3 lymph node, you still cannot really tell that this is positive or not. So the advantages is a high sensitivity and negative predictive value. You can biopsy lymph nodes above 5 millimeters. You should biopsy lymph nodes above 5 millimeters. And then you can access pretty much all these type of lymph nodes. You cannot access 3A or 5 or 6 stations, 3A, 5 or 6. There's a learning curve, and you cannot, lymph node stations 8 and 9, there were some studies done before in which you go with the EBAS-TBNA bronchoscope down the esophagus while after doing the EBAS-TBNA mediastinal staging to assess for stations 8 and 9. Pretty much when you find them, is ideal, but only you find them less than 3%, so it's not really that much, and it's not going to change because most of these patients have already a station 7 positive. And station 7, 8, and 9 belong to the lower mediastinal lymph node zone, which is not really going to change anything in terms of survival. Yes?
Is there a role of doing EBAS and EUS together? Because sometimes, the guidelines talk about it often to do them together. I know that's something we don't do.
Correct. And I'm going to show you that right now and show you some examples of that. But yes, there was a study done which showed that there was mediastinoscopy versus that approach. And that approach seemed to be better. However, the EUS didn't seem to provide that much information compared to EBAS. There has not been any other study after that. Cervical mediastinoscopy. gives you a sensitivity of 80%, a specificity of 100, and the video mediastinoscopy is 90% sensitive. Of course, the surgeons like to do this in some places. Here, rarely you end up having a mediastinoscopy. EVAS has been compared to mediastinoscopy in this prospective study in more than 60 patients with enlarged lymph nodes, and the gold standard being the lymph node dissection, meaning surgery via by VATS or by thoracotomy. The diagnostic yield per lymph node was better in the EVAS group compared to mediastinoscopy. This is the study that I was explaining to you earlier. This is in more than 200 patients. They randomized them to either go for surgical staging, mediastinoscopy, or they receive EVAS plus EUS, and if the lymph nodes were negative, then they did the surgical staging, which is pretty much patients go for surgery and then go for a lymph node staging at the moment of surgery, and if that's negative, immediately they proceed with removal of the lung or the lobe. So you can see here the sensitivity was better in the group that received the EVAS plus EUS plus a surgical staging versus the surgical staging alone. So the advantages is it's really a low mortality and morbidity procedure, mediastinoscopy, and probably the access is fair. You can access lymph nodes 1, 2, 3, 4, and 7. You cannot access lymph nodes 5 and 6 unless you do the Chamberlain's procedure, right? Which is a type of mediastinoscopy, right? It's an anterior-cervical mediastinoscopy. And it also has a lower sensitivity compared to an EVAS TBNA. Now the next way, or the other way of doing this, is transthoracic needle aspiration. You just go with a CT-guided aspiration, needle aspiration of the lymph node. Usually anterior lymph nodes are performed that way. Has a good sensitivity, but the lymph nodes have to be bigger, 1.5 centimeters or bigger, in order for them to access. Complication with pneumothorax, up to 10% will get a chest tube, and you can only do one lymph node at a time with this procedure. And it's mainly used for diagnosis rather than for staging. VATS, it's a relatively, the surgeons will say, simple procedure. You can go from the right or the left. The complication rate is not that high unless you have to convert into a thoracotomy. It gives you a better evaluation of a T, of the tumor itself, because now you're seeing it, surgically you're seeing it. Is it really involving the pleura? Something that the CT scan didn't give you. And not only that, but patients sometimes go for VATS for supposedly stage 1, and then they just end up having finding a pleural metastasis. So it's already an N1 disease, but the diagnosis was made right there during the surgery. And unsuspected malignant effusions with this found in 6% of the time. So when you talk about invasive staging techniques, you have all the techniques here on the left side. And then you have all the lymph nodes here on the top. So stations 8 and 9 can only be, mostly be done with EUS. This is important for you to know. It can be done by EVAS. Has been done in a couple of studies. Stations 5 and 6 can only be approached by extended mediastinoscopy, the Chamberlain's procedure, or the Chamberlain procedure, or the left VATS. And then the other lymph nodes, pretty much, most of them can be accessed by EVAS. When it comes to sensitivity, EVAS has the highest sensitivity of all the compared to other techniques. So let's go back to what we did in half of the talk. Remember the groups, the A, B, C, and D. Based on what we know now, what are the recommendations? when do we really do mediastinal staging? Yeah. So, for the group A, with the mediastinal infiltration, there's no need to do a mediastinal staging. Patient has already invaded most of the lymph nodes. There's no differentiation among lymph nodes. All you need to do is take a biopsy from here to get a diagnosis, or from any other place that is suspected for cancer. Group B, the ones that you were able to see the lymph nodes clearly, they were enlarged more than 1 centimeter in the mediastinum. So the recommendation is invasive staging is recommended. So one of those techniques that we discussed about. But which one is the preferred? And the preferred is going to be EBUS. Or if there is an 8 or 9 lymph node, then EUS. Or any other technique that involves needle. Okay, so needle aspiration of the lymph node for technique of mediastinal staging. And then that's going to be followed by surgery if it's non-diagnostic. And by surgery means mediastinoscopy or VATS. The group C that we talk about with either the Hilar lymphadenopathy or the centrally located tumor, the recommendation is patients do need invasive staging, regardless of the PET or the CT scan. And it can be done with EBUS, TBNA, or AUS, similar to the group B. And the group D, this is where the debate happened a few minutes ago. A non-invasive staging is sufficient by the guidelines so far. There's still not data that supports, or not enough data that supports that we should perform mediastinal staging in these patients. So if the PET scan shows, if the CT scan and PET scan shows lymph nodes that are less than 1 millimeter and they are not hypermetabolic, patient goes straight for surgery. So conclusions. CT chest with contrast is definitely the first step for evaluation of lung cancer, as we talked about it. PET scan for evaluation of distant metastasis can be used, not necessarily for mediastinal metastasis. Please do not order a PET scan just to see how the mediastinal looks like, because that's not the way to do it. MRI of the brain is indicated if you suspect that the patient has a clinical stage 3 or 4. It's important for us to know to have knowledge in terms of thoracic anatomy and lymph node drainage pattern, as we already talked about. Mediastinal staging of lung cancer, of non-small cell lung cancer, could be invasive and non-invasive. We use the invasive method all the time to try to prove that the mediastinum has not been invaded by tumor, if it's indicated. And EBUS TBNA is the first-line procedure nowadays for mediastinal staging. But still the gold standard for mediastinal staging is a lymph node dissection. It's a surgical procedure. Any questions?
So if you have a situation where the hilar, ipsilateral hilar lymph node is enlarged, and you want to do mediastinal staging, you still have to go to N2 nodes, controlize it, and look at them and biopsy them, even if they look normal on CT or PET scan.
Correct, and the reason for that is, as I said, you still can have hidden metastasis to the lymph nodes. So now, the way how we do it, in EBUS, in bronchoscopy, and I didn't want to go into details about it, we always start with the N3 lymph node first, evaluating and biopsying that, and then go to an N2 lymph node, and then go to N1 lymph node. That's the way we do it all the time, in the same way, regardless. So whenever we do mediastinal staging, we always start in N3. We look for every lymph node in N3, then N2, then N1, whenever it's indicated. So we don't just go for the lymph node that is enlarged or positive on the PET scan or the CT scan. Any other questions? Yes?
You ever run into any situation where the only way to get to it would actually be doing it by not doing a bronchoscopy, by doing the evaluation, endoscopy of the esophagus to get to some of the lymph nodes in the chest. I remember a case I had years ago before you guys started doing all this fancy stuff, where Mr. Rosati made the recommendation that we get Ben Menachem, who used to be here, to do some of his fancy stuff by going through the esophagus.
Right. So that will be the EUS, which is pretty much it's an EVAS bronchoscope, but it's an endoscope, much bigger, with tools that are much bigger too. And you assess everything that is around. So because through the esophagus, you can see, for example, a subcarinal lymph node. You can even biopsy 3P through the esophagus too. For left maybe, for right, very hard to do.
That was the only abnormality he had, was just in that region where it was contiguous with the esophagus.
Right.
And we were trying to figure out how would somebody get to that without, there's not a surgeon. How could we get the diagnosis? So we gave it to the GI brothers.
Yeah.
They got it. But actually, what I was going to actually do is, that if you saw that, would you do that, or would you defer to the GI?
Well, if you see any lymph node that is in the mediastinum, the patient needs to have a complete mediastinal stage.
Okay, I see.
So, regardless where that abnormal lymph node is located, you still need to look for every single lymph node, because you're going to find, as I said, up to 20 or 25% of the times that is positive. Yes?
If you have high suspicion and you do the EBUS TDNA and you find lymph nodes that are greater than 5 millimeters, but you get nothing on tissue, and so the next step would be thoracic surgery, or do you present this to tumor board? And you have
Well, the next step, if the patient is going to go for surgery, like if I'm doing this to try to stage the patient because there's nothing extrathoracic, right? So I'm just doing that I'm just dealing with the mediastinum. The mediastinum is showing that it's not diagnostic because I didn't get to the tissue, it was just too tiny or so. When the patients go for surgery, they're going to go for VATS usually, and they have a whole lymph node dissection. So as I said, that's exactly how surgery approaches them. They have the entire lymph node dissection. They send it immediately for a pathology, for frozen pathology, and they have the answer within 5 minutes or 15 minutes. And then if any of the lymph nodes come back positive, then they do the whole staging again in surgery. If this is an N1 lymph node that came back positive, then they proceed with the lobectomy. If it's an N2 lymph node that came back positive, so maybe it's not a good idea to do the lobectomy. So they have to do the whole restaging again in surgery while they're doing the surgery. Any other questions? Thank you.